heard about anti-TNF as a possible treatment. We've heard about bone marrow transplantation as a possible treatment. We've heard about at least the possibility eventually of gene therapy as a possible treatment for DADA2. And maybe just to get things started, because I know this will probably be a question that the patients and families ask us, so I'll direct this to the gene therapy representatives here. About when would you guys think that it would be possible to have an active gene therapy protocol in place? I would guess we'll be asked that question.
This is the $1 million
question.
Dollar question. Okay, I can answer simply. I mean, for ADA-SCID, I think overall it took 15 years, but at that time in 1995, when the group published the very first paper, I mean, nothing was in place. I mean, now we know much better how to deal with the patient, how to transduce cells, which cells we have to transduce, how to produce the vector, which is very important. So, so I don't have a clear answer, but because I think at the moment the big issue in the field, maybe my colleague can also comment on that, is the lack of a suitable mouse model in which we can test the efficacy of the therapy. Because we all know that there is no mouse ADA2, and so that's, I think, probably one of the major problems that we are thinking of facing in the coming years. Of course, it depends also very much on regulatory agencies. Because, of course, we are using vectors very similar to other clinical trials, was, for instance, MLD that we have in the institute. But, of course, the safety issue, the efficacy issue it will be there. So we need to have a suitable model to study efficacy. Maybe, I don't know, just to go back to your question, maybe between 5-10 years, 5-7 years, something like that.
Despina, would you go along with that general assessment?
Yes, but I'd hope we can do it sooner.
Okay. Well, are there comments? Okay, Gigi.
My question is for Isabel. Very interesting results about transplant, but also, as you pointed out, some problems, in particular the graft failure. So some of the protocols appear to be a little too gentle, perhaps. But on the other hand, you know, with ADA2 deficiency, you wonder whether there is also a hyperinflammatory state that may, in fact, favor graft failure, as seen in other settings like interferon gamma receptor deficiency or anything like that. So are there any biomarkers that may help identify patients who run into this problem? Or, alternatively, if we don't have those data, would it make sense actually to collect specimens pre-transplant and use those samples to run these studies to identify predictive biomarkers of graft failure? A related question is, do you think that thiotepa plays a crucial role in favoring engraftment and dampening inflammation?
So, first question, biomarkers to monitor inflammation prior to transplant, I think those would be very useful. So, I definitely agree that the presence of inflammation prior to going to transplant and prior to conditioning, and then the added inflammation of the conditioning regimen will play a role in graft failure, together with maybe with the viral reactivation seen in 50% of the patients. When we had the problem with our second patient, we started measuring serum cytokines in this patient. We actually saw that prior to graft failure, he had a rise in TNF-alpha, in IL-6, and in interferon alpha in the serum, which went down again upon engraftment after the second bone marrow transplantation. So I think it would make a lot of sense to collect serum samples, or maybe even more, and go into even interferon signatures as we've seen before, or do mass serum analysis of different chemokines and cytokines to either measure or predict that something could go wrong. I also think that pre-treatment, probably with anti-TNF agents, could play an important role in these patients. Although we have to be careful also, I think, on the other hand, because sometimes you can see also the pancytopenia and the marrow failure developing due to etanercept. So I think we need, if we go further with this transplant, it would be good that indeed we start collecting serum, plasma samples, and other samples of these patients. I'm thinking of, I think, even PBMCs prior to transplant to see if we can develop a strategy even based on mRNA profiles. The second question, the place of tyotepa. Well, actually, if we look at graft failures and the need for retransplant, we cannot say that it's only in the RIC conditioning regimens. Actually, not at all. So also, it's not related to the presence or absence of tyotepa in the protocol. And I also heard from a patient transplant in Jerusalem with Paulina. She actually used Treo, tyotepa, fludarabine, and Campat, and the patient rejected. So it's not really, in my opinion, related if we set out the conditioning regimens to any other regimen. So I think there probably inflammation that is going on plays a role more importantly than the conditioning regimen. But of course, we are only 20 patients or 23 patients ahead, so we need to probably gather that again and learn from it and go more prospectively in the future patients.
One issue, no, it's not related to that one, but one issue that was raised before was that we need really personalized treatment for this disease because it's so heterogeneous. And I mean, I do appreciate the preclinical studies for, gene therapy, but I mean, it would be hard. This is not SCID. So I mean, in a 7-year-old who does fine with 2 shots of anti-TNF per month, or a patient who's fine with, blood transfusions every 3 months with iron chelation, I'm not sure I'm going to go at least today, with this experience with, gene therapy. But of course, we need to do these, and, maybe in 10 years, it will be easier.
Yeah, well, at the last meeting, I remember that we had a discussion towards the end in the last discussion group about the question of, well, even though it may be the case that a patient is tolerating an injection of an anti-TNF at whatever frequency and doing just fine, on the other hand, you do have the issue that you have a patient, maybe a 5-year-old, who potentially could be on an anti-TNF agent for his or her whole life, and we really don't know, what will be the long-term effects of that over 70 years or something like that of anti-TNF therapy. And of course, at least in some settings, the cost of that is quite high. And if one balances that against the cost of doing a bone marrow transplant, even though we've heard that it's a rocky course for some of the patients, one could, on the other hand, say that eventually, once one gets past that rocky course, and assuming that there isn't some terrible catastrophe around the time of the transplant, that then the patient would be cured.
No, I agree with that, but it's just personalized treatment, really, that I want to highlight. And I would be happy to give my colleagues' email for those 3 patients because I don't know what, regimen they used. Isabel.
Mike.
Yeah, I just wonder, Isabel, or any others who have done the transplant, whether the kind of biomarker that might be useful is also plasma ADA2 activity, and whether both as a marker of engraftment and stability of engraftment, but also potentially of ongoing virus reactivation or inflammation. Do you have any thoughts?
I think so. We did this in the second patient that we transplanted, and unfortunately, I wasn't present when he rejected. But I think it would have told us something if we would have measured it at the time he was starting his pancytopenia. If at that time the ADA2 level would have gone down, it would have told us something. And I think serial measurements of ADA2 post-transplant and peri-transplant are, I think, actually very useful. If it's feasible, that's another question, because if you all start to do that, you're going to be very busy. And
well,
also,
we're doing it in a few, but
and also I don't know if it's not specific At some point, when it rises, as you say, it can be viral reactivation, but it was a good addition, and it showed us at least what was going on with the engraftment. It actually followed and paralleled the engraftment. Yeah.
I have one question for the gene transplant people. You mentioned the lack of a mouse model, but did that really hold back developing gene therapy for ADA1 deficiency? I mean, knockout mice were used later on for various reasons, but they certainly weren't used in any real way to get the ball going.
Do you want to answer?
Yeah, so I guess in my mind, why do we actually need the animal model? So there's two different questions we will be trying to answer. So one of them is safety, and you don't necessarily need to answer the question about safety, an exact animal model for DADA2. And then it's efficacy, and I guess that's what we may be asked to have an animal model for before we actually move on to actual patient clinical studies. I suspect it's all about regulatory approvals, etc. as well. You've seen some of our data, you've seen the Intalia Group's data, so I think we're progressing the work nevertheless.
Well,
despite the fact
let me ask you
this is not-
theoretically, and maybe it's way too early to answer it, but what kind of patient would you envision would be appropriate for initial trials of gene therapy?
So I guess if we go on the experience of obviously other diseases and the current challenges we have with treatments that are currently available, I suspect the patients with immunodeficiency or hematological manifestation might be the first ones to target. But coming back to Cesar's point previously, I think we have to hear what the patients want us to do as well, and I think very much what they're all looking for is a cure, not just a treatment for a few years to come.
Let me ask it another way. Would you imagine first doing it in an adult who could give consent?
I guess, yes, maybe that needs to be the case. We wouldn't necessarily start with children. It may have to be a young adult who we go ahead with, who gives their own consent. I guess I'm a pediatrician myself. I don't know which way things will go, but yes, that's a sensible approach.
Hi, sorry, just a comment on this. I think on the basis of our experience in Italy, we can even think about a staggered strategy in which we can treat first adult patient, but I would say without hematological manifestation, because we have to retrieve autologous stem cells. So they have to be able to mobilize stem cells, and then we can treat adolescents and then children. So it could be a way.
Yes, Kathy.
This is probably related to Gigi's question, but more specifically, for the transplants, was myeloablative conditioning therapy used? And then the other question I have is for gene therapy, would you need to use myeloablative conditioning prior to gene therapy as well to get out, say, the T-cell infiltrates or the inflammatory cells that may be causing bone marrow failure?
So there's been at least 2 patients who got busulfan cyclophosphamide, and then there's the entire group who got the triosulfan, which is less strong, but together with thiotepa should be or would be considered myeloablative. Several patients received irradiation as well on top of the trio and the cyclophosphamide. So I would consider that about 50% of them got actually myeloablative conditioning. And it was not related to graft failure, yes or no. And then for the gene therapy, I suppose
I assume it's the same. I mean, for gene therapy, I mean, Maria Pia can answer this question.
Yeah, of course.
Yeah, we need myeloablation.
Low toxicity, myeloablative. Yeah.
Yes.
Fabio.
This is a question for Despina. In your cell line experiments, you show that you have a reconstitution of enzymatic activity several times higher than normal, but the inflammatory phenotype was not corrected, not totally corrected, right? Was lower. It was the inflammatory phenotype of the cells were still closer to wasn't normalized.
So TNF, we looked at TNF alpha production, and it actually was closer to the healthy wild-type cell levels. We are doing a number of experiments looking at reversing the actual M1, M2 skewing data that I've shown you. I don't have the results to show you today, but that's work ongoing, and it's looking good.
Right. But I was expecting a complete normalization given the high enzymatic activity. So I was wondering if that says or tells us that for this gene we would need endogenous control of gene expression, or if, going back to the discussion of this morning, the readout of the enzymatic activity is not the real one that we need to look for.
Yes, indeed, and I guess that's why we want to have a number of different readouts. So we want to look at protein expression. We now have this flow cytometry antibody that can allow us to look actually at quantifying the protein expression and relate that to enzyme activity. We want to look at immunophenotype and interaction with endothelial cells. So not just one readout that we're actually to reverse, we're trying to reverse with this approach. I think the other thing I should probably say is it's the beginning of this experiment with titrating our MOI and our transduction efficiency, so we can fine-tune these experiments to get it just about right.
Yes, please.
I just would like to have a comment on the graft failure. I don't foresee this of big of a problem because two of those patients that Isabel presented were transplanted from diseased siblings, and that was before description of the disease, so those were not screened. And another one with a low cell dose. So that the percentage of graft failure for all the cohort we have is 5 to 10%, which is kind of acceptable for a non-malignant disease. My second comment is I'm happy that we reached a consensus, I think, for the intrinsic and extrinsic problem for bone marrow failure anomalies. Not all hematological presentations are the same, but from all the presentations, I think the puret cell aplasia or the bone marrow failure in general represents an intrinsic problem, and it seems to be resistant to anti-TNF, like in Turkey and St. Jude and some of the NIH patients as well. Others, like neutropenia, I think it's difficult to see if it's intrinsic or extrinsic, but the bone marrow failure phenotype in general would respond to transplant better than anti-TNF. Thank you.
Okay, other comments or questions? Yes, please.
Yes, as a basic scientist, sometimes I feel this talk about treatment, especially gene therapy, is going very fast. It's very difficult to catch up with the basic science. For example, when you do gene therapy, do you have control of how much enzyme activity is produced? Because if you produce too little or too much, it can have some effects. And the second thing also, we don't know exactly about the regulation of enzyme activity. It can be regulated, and that can also be a problem with the gene therapy. And also concerning the mouse model, I think that the mice must be producing some ADA2-like activity, which I would just love to try to find, and then
Yes, I do agree with you.
maybe
I think there is
use it as a
something
model.
else.
Yes.
Yeah.
Yeah, only, you know, we were, at least in part, responsible for that now conventional wisdom that there isn't a mouse homologue. And I stand by that in terms of the investigations that we did, but, you know, certainly it could be that there's something that's, you know, somewhat like ADA2 that we just didn't find in our screens, you know, in terms of homology searches, that actually could be targeted, you know, as the mouse homologue. So I think that that deserves re-examination. I agree with that. Yes.
Has anyone looked at doing serial sequencing on these patients to see if they acquiesce any other mutations like we see in some of the pre-myeloid, pre-clonal neoplasms?
Well, it seems like, at least right now, that's not being done. It's the same question as what we were talking about, I think, earlier today with regard to, for example, having a cohort of patients with Hodgkin lymphoma and seeing whether or not at least some percentage of them might have somatic mutations in ADA2. And certainly that would be of great interest, and serial sequencing would also be of great interest. Yes?
I have a question for Dr. Ombrello. I was quite distressed to see the patient that you presented whose digital gangrene is getting worse. He's actually my patient who was sent to NIH. So I'm just kind of distressed that, this young man who did not have a stroke since the last stroke he had was at age 15, and now he's 28, I think. And so do you think the anti-TNF could be making his digital gangrene worse?
Well, thank you for coming, the very good Dr. Dinza, who is thought of oh so highly. I've questioned that in my head sometimes whether or not we made the situation worse. But we got angiograms on him at the outset, and I didn't put that actually in the presentation. But it is really appalling. We have all 4 limbs. And the lack of blood flow to the extremities has been there. So I think he was on the road to this inevitably, and I don't know that we hastened it, even though I've questioned that, because when you catch him, when you first have him take his socks off in the photography room, it doesn't look as bad as it does after he's had his socks off for a few minutes in there, and it gets much more blue. But I do think that he came to us in bad shape, and he's only progressed since that time.
It doesn't help that he lives in Manitoba.
Right, and he's a farmer who bites his knuckles.
Yeah, and I guess one other question with regard to this. I mean, I think that the point is well taken, and of course, he's been on anti-TNF for a long period of time. There aren't that many patients who have been on anti-TNF for the length of time that he has. I guess that the Israeli cohort would be one where there are a few patients who were empirically started on anti-TNF for their polyarteritis nodosa back 10 years ago or something like that. It would be interesting to see if they have any such patients. Is Yaakov still here, or? Oh, Yaakov, there you are, yeah. Oh, you're supposed to be paying attention. So the question was, in the Israeli experience for the patients who were treated with anti-TNF 10 years ago or whatever, the first patient or patients who got infliximab for PAN, have they developed any problems with digital gangrene? No. Uh-huh. Uh-huh. And what is your longest experience? 18 years. Okay. Okay. All right. Marco?
May I ask some more insight in this patient? I mean, is it active in terms of acute phase reactants? Do you use iloprost in this patient? And if you measure TNF or something like that, I mean, can you speculate a little bit? And which kind of anti-TNF treatment?
So he was initially started on adalimumab, and then he's been switched to golimumab, and we give it weekly in him to try to, instead of monthly, to try to really help him. We've escalated as things got worse. He takes iloprost, he takes calcium channel blockade, he, Cialis, yes, he takes Cialis as well. So we're trying to maximize what and his inflammatory markers are normal and have been normal, and he hasn't had really a lot of breakthrough since he's been on anti-TNF. In fact, he feels great. He says he feels better than what he used to feel before he went on anti-TNF. He just gets these, this ischemic digit that once removed, he's back to feeling great again.
He did have elevated inflammatory markers prior to starting on anti-TNF.
Yes.
I was just curious if if bone marrow transplantation would have any effect on that phenotype with the severe digital vascular disease?
I think in him, part of the problem is he was 20-something years old before he was started on treatment, and therefore he had that much time to accumulate the damage. And so that's why I say I can't say for certain that the younger patients who have a Raynaud's component to disease, that we aren't going to be able to significantly slow or halt that. I can't say yet, because thank goodness in our cohort we don't have anybody else who has progressed to that. We do know there is some significant peripheral vascular disease now that we're really examining all the patients. We see that it's there, but no one else has progressed like that.
Well, and you think about it, I mean, in other causes of severe peripheral vascular disease, usually by the time that someone gets to that point, it's very hard then to medically or surgically intervene to really stop the progression. So I would imagine that bone marrow transplant might help some, but it's kind of, at this point, the horse is out of the barn. Now, Paul wanted to comment or question.
At the conference 2 years ago, Isabel put out a call to describe all the patients who'd ever had a bone marrow transplant. Actually, we need to do something similar for anti-TNF. It may be shocking to this audience, but in the UK, DADA2 patients cannot routinely access anti-TNF. My patients get it because I fiddle the system, and it comes into sharp focus when they become young adults and I need to transfer their care. It may be a bit like the word on the street about FMF, that it would be unethical to do a study that the depth and the breadth of the knowledge in relation to anti-TNF would mean doing a clinical trial might be unethical. But I don't have enough data to persuade my government to allow me to prescribe anti-TNF for pediatric patients or even adult patients at the moment. So perhaps one outcome of this meeting, and I think an urgent unmet need, is to try and in some way pull together all the patients who have ever received anti-TNF. And Amanda, publish your experience, because where's the paper? My government won't look at any abstracts. We need a paper.
You can mention where is it?
Yeah, so it's at the New England Journal right now with the being reviewed by the editors. So hopefully, I mean, it's not accepted yet, but hopefully it will be.
It's been revised and resubmitted, so it's got a lot of our data as far as the anti-TNF.
So I'm a believer. I believe that anti-TNF works, but I'd be interested in a show of hands to think that if we were to conduct a trial, would that be an unethical trial? In other words, would anyone be willing to randomize a patient to anything other than anti-TNF? Hands up if you would be willing to randomize to something that's not anti-TNF.
Yeah.
Okay, let's use a
problem of like
pan phenotype. Digital ischemia, had a stroke, CRP's 30.
Not for PAN, but for hematology, yes.
No, I'm not asking about hematology. I said that pan phenotype.
No, I think that's the question, is for the pan phenotype or for stroke, would one consider it ethical to randomize someone?
And so if the answer is no, we someway need to pull that together so that when my government says you're not getting anti-TNF because you've not done a trial, I can then say, well, the international community think it is unethical to do such a trial. See what I mean? It's a really important priority.
So would the EMA really require a placebo, or if you were able to do one TNF inhibitor versus another and everybody improve, would that be sufficient data?
I do. The regulators, when I'm being a regulator, would say we require adequate data. Placebo-controlled trials are the easiest, but they are not the only data which is acceptable if the data is strong enough.
Can I ask just one question for both transplant and gene therapy? How do you envision either of those modalities affecting the risk of stroke?
We're all looking at each other, so clearly haven't thought this through. I guess my thinking around this is that's why we're exploring the effects of transducing the cells and interaction of monocytes with the endothelium, so we can actually get some robust readouts what we're actually doing to the endothelium. So perhaps that can inform our strategy in the future.
Okay, are there any other comments or questions? I think that we actually have at this point exhausted our, and I use that word informedly, exhausted our 30 minutes.